A very good day to one and all. So welcome back to another session on pediatric surgery. So I'm Dr. Rohit Gopinath, and today we'll be discussing about another very important topic in pediatric surgery, biliary atresia. Biliary atresia is the most common surgical cause of jaundice in infancy. The basic definition of biliary atresia is that it's an obliterative disorder involving both intra and extrahepatic ducts. Basically, it's a panductular cholangiopathy. So, history of pediatric surgery and biliary atresia in particular, the terminology John Thomson is very commonly associated with it. So, John Thomson, in his thesis actually way back in 1891 on obliterative disorders involving the bile ducts, has described a case series of biliary atresia. This was in 1891 I'm talking about. Mario Kasai, the name is synonymous with biliary atresia. He was a very prominent surgeon who was initially in Japan, subsequently started practicing in the US, who has studied biliary atresia in detail. In fact, he was the one who suggested that biliary atresia is a progressive disorder which seems to involve the extrahepatic ducts first and then progresses to involve the intrahepatic ducts. He dwelled into the histology of the fibrosed remnants in the portal tract and found that the ductules were completely obliterated, tubules were plugged, and all these findings were described by Mario Kasai. And he proposed that surgical intervention, if done early, before the progression from extrahepatic to intrahepatic ductules, can arrest the progression of the disease process itself. His surgery, Kasai's potoenterostomy, is still the gold standard in the management of biliary atresia. Thomas Starzl. So, Thomas Starzl performed the first liver transplantation. In fact, he found that even though his patient passed away subsequently, he is still credited to have initiated the movement towards liver transplantation. Now, as I had repeatedly said before, no topic in pediatric surgery is complete without an analysis of the embryology behind it. So, the foregut, as you can see here, from its ventral aspect gives rise to what is called as a hepatic bud. The hepatic bud grows into the ventral mesogastrium, as you can see here. And as it grows, it divides into two components. One is called a pars hepatica, another one is called as a pars cystica. Now, the pars hepatica progresses up into the ventral mesogastrium and it combines with the septum transversum to form the liver. The pars hepatica divides into two branches at its terminal end to form the right and left hepatic ducts. The rest of the pars hepatica forms the common hepatic duct. The pars cystica develops into the gallbladder as well as the cystic duct. The remnant hepatic bud here forms the common bile duct. Okay, so this is the basic embryology behind the development of the biliary tree. And all this is complete by around 4 to 6 weeks of gestation, approximately 30 to 35 days. So let's now come on to the epidemiology of biliary atresia. The incidence of biliary atresia seems to vary between the western as well as the eastern populations. You find that its incidence is 1 in 15,000 to 1 in 20,000 in the western population, whereas seems to be more common among the Asians, particularly the Southeast Asians. In fact, the highest incidence of biliary atresia is noted in Taiwan. Biliary atresia with splenic malformation, which is one of the types of biliary atresia, is more common in the West as per literature. There seems to be a seasonal variation in the occurrence of biliary atresia, with it being more common during the winter and the rainy seasons. And females tend to get involved more than male children. So, coming on to the types of biliary atresia. Now, there are two classifications for biliary atresia. One is the Japanese Association of Pediatric Surgeons classification, which we will deal with later. And another one is based on its appearance, based on its occurrence and etiological factors. So, this classification basically divides biliary atresia into 4 different types. One is called BASM. BASM stands for biliary atresia with splenic malformation. It is commonly associated with other conditions, for example, malrotations, preduodenal portal vein, polysplenia, which accounts for the splenic malformations, It can also be associated with interrupted IVCs, etc. Now, this association, so why does biliary atresia combine itself with splenic malformation? There are many etiological factors which are said to contribute to its occurrence. Gestational diabetes mellitus and in vitro fertilization are said to be one of the factors which can incite a biliary atresia with splenic malformation. There are genetic defects which are said to contribute to its occurrence, which are non-Mendelian in nature. That is, they don't have a pattern as such. Now, there's one particular gene which is called as a CFC1 gene, which seems to get involved, or which is said to be defective in a child with biliary atresia or splenic malformation. Now, the association of biliary atresia with splenic malformations and other vascular malformations seems to be more related to the time when it occurs rather than the genetic predominance or the genetic defect. The common time when this particular defect seems to occur is around the 30 to 35 days of gestation, during which time you have the development of the spleen as well as the major vasculature in the region of the liver, developing liver. So, the association between biliary atresia and splenic malformation seems to be more related to the time at which the defect occurs rather than a genetic component to it. Now, there's another variant of biliary atresia, second variant of biliary atresia called a cystic biliary atresia. It accounts for 10% of biliary atresias and it is characterized by the formation of a cyst. In a cyst, proximal and distal to the cyst, the biliary tree is obliterated. This cyst is usually filled with mucus or might contain bile as well. It's a common differential diagnosis for a choledochal cyst. We already discussed about choledochal cysts in our previous classes. A classical intraoperative cholangiogram appearance of a cystic biliary atresia is a pruned tree or a cloud-like appearance, as you can see here. Now, it is one of the better variants of biliary atresia in the fact that it has a better response to surgical intervention. Now, CMV or cytomegalovirus associated biliary atresia is the third type of biliary atresia. Now, the very fact that viruses are associated with biliary atresia was first postulated by Dr. Landing. There are many viruses which were considered, for example, the reovirus type 3, cytomegalovirus, Epstein-Barr virus, rotavirus, HPV or human papillomavirus. All these were considered to be associated with biliary atresia. But conclusive evidence regarding association with biliary atresia was noted only with cytomegalovirus. In fact, there was a French study in which they were able to document the presence of anti-cytomegalovirus antibodies in the maternal blood and IgM immunoglobulin against cytomegalovirus in the blood of the newborn child who was diagnosed to have biliary atresia. So, these children to be called to have CMV associated biliary atresia, children should have associated IgM positivity. That is, cytomegalovirus immunoglobulin M positivity should be associated with it. So, these children who have IgM positivity for cytomegalovirus with associated biliary atresia seem to have markedly deranged biochemical values, have a delayed presentation time because everything is attributed to the viral infection and the surgical possible cause of jaundice is not thought of early. And these children also have a marked inflammatory response, rapid and severe inflammatory response, resulting in early progression to liver cell failure. Response to poor surgery is generally poor in children who have an associated CMV infection. But the point here is that even though CMV associated biliary atresia, children are said to be IgM positive, the actual virus is not generally seen or has not been demonstrated till now. So, use of ganciclovir therapy, which is an antiviral drug, is again controversial. Now, the reason why cytomegalovirus is said to cause biliary atresia is possibly because of a viral mediated immune response. This immune response triggers an inflammatory response which is so aggressive that it causes an auto-digestion or auto-destruction of the biliary tree. The fourth and the most common variant of biliary atresia is the isolated biliary atresia. Now, its origin is it's a mystery actually. Why it occurs, nobody knows. And it is said that most of the cases of isolated biliary atresias, the biliary tract is normal at the time of birth. And all the changes that occur in the biliary tree occur in the postnatal period. A viral association is also being considered in isolated biliary atresia, even though you find that we are not able to demonstrate the actual presence of the virus. So, developmental biliary atresia is a terminology which we come across very commonly in biliary atresia. So, this includes two types of biliary atresia, namely the BASM type and the cystic biliary atresia. So, both these, the reason why they are called come under the top heading of developmental biliary atresia is because their occurrence is said to be in the prenatal period. And as a child develops, as a fetus develops, this disease progress also develops. Now, another terminology which is commonly associated with biliary atresia is called bilious trazone. So, bilious trazone is basically an agent which is noted, which is present in red weed. Its effect has not been documented in adults or in humans as such, but it's in those sheep who have fed red weed. They were found to develop biliary atresia at a later date because of the effect of this particular chemical in it called biliotrazone. Now, so what is the basic pathology associated with biliary atresia? Now, basically it is a marked inflammatory response. There is an inflammatory component which overwhelms the normal anatomy and seems to destroy the normal biliary anatomy. So, what are the effects of this inflammatory response? There are few important points regarding it, which are classical histological findings in biliary atresia, namely ductular proliferation, that can be bile stasis, tubular plugging, periportal fibrosis, and giant cells. Now, so we can see here, this is a picture of a child with biliary atresia. These red spots that you can see are basically plugging of tubules, and you have ductal proliferation you can see in this region. You also have associated periportal fibrosis. This is a normal anatomy of the liver. You can know the difference between both these here. So, why does all these changes occur? Now, as I said earlier, it is an immune-mediated response. So, class 2 antigens are said to play an important role in its occurrence, along with ICAM and VCAM. So, ICAM are intracellular adhesion molecule and VCAM are vascular cellular adhesion molecules. These levels of these markers seem to be high in the biliary apparatus and the biliary tract of children associated with biliary atresia. These facilitate the entry of mononuclear cells and their activation as such. And these mononuclear cells which infiltrate and get activated cause an autodestruction of the biliary tree as such. So, mononuclear cells which commonly infiltrate and are activated are basically the natural killer cells as well as the T helper cells, basically CD4 and CD56 cells. There are another group of cells called Th17 cells, which are basically which encode for or which produce leukotrienes, interleukins. So, these produce interleukins which are said to again incite an inflammatory response. Now, the normal biliary tree seems to contain a lot of Toll-like receptors, and these Toll-like receptors are said to again have an increased or exaggerated response to immunogens, and subsequently resulting in the stimulation of an incitation, or it incites an inflammatory response. Now, Kupffer cells. Now, Kupffer cells are basically macrophages, and these macrophages have two functions. One is they present the antigen presenting cells, as well as they incite an immune response against it by recruiting helper cells. So, they are also said to be implicated in the inflammatory process associated with biliary atresia. Now, CD68 is another T cell which is again said to be the reason, elevated levels of CD68 is said to be the reason why progression of biliary atresia or progression of inflammatory process can occur even post-surgical treatment. So this is a chart which kind of summarizes the types and how they occur. So you can see here BASM, which is biliary atresia with splenic malformation, occurs in the first trimester, as I had said earlier, by around 30 to 35 days. And one of the causes is maternal diabetes mellitus along with in vitro fertilization. Mutations involving the CFC gene is said to contribute to its occurrence. Now, a response to when the presence of a susceptible gene stimulation, immune damage can occur, which is mediated by class 2 antigens, intercellular adhesion molecule, vascular cellular adhesion molecule, which subsequently reduces, which increases CD4 as well as which are T helper cells, as well as natural killer cell levels are increased, inciting an inflammatory response causing autodestruction of the biliary tree. So this immune damage need not always be genetically mediated. It can also be brought about by viral infections, particularly cytomegalovirus, reovirus, rotaviruses, etc. The cause for cystic biliary atresia is still not known. It is possibly a second trimester insult. Now, coming on to the next classification of biliary atresia, which is a Japanese Association of Pediatric Surgery classification, wherein you divide it into 3 different types. So, based on the extent of biliary involvement. So, biliary atresia is one condition where the extent of biliary involvement goes from distal to proximal, that is from the bowel towards the liver. So, type 1 biliary atresia basically involves the distal CBD, only the CBD right up till the cystic duct, combining of the cystic duct with the common hepatic until there. So, basically type 1 is obliteration of the common bile duct. Type 2, it extends right up till the confluence of the right and left hepatic duct. Type 3, which is the most common, seems to involve the entire extrahepatic biliary apparatus. It can be associated with a gallbladder, which can be filled with mucus, or an atrophic gallbladder. Either way, type 3 is the most common type of biliary atresia as per the Japanese Association of Pediatric Surgery classification. Now, what are the clinical features of a child with biliary atresia? So, these children generally present themselves in the early infantile period or newborn period with progressive jaundice, acholic stools, dark urine, firm hepatomegaly, which is initially attributed to physiological jaundice. But to be remembered, physiological jaundice is usually unconjugated. Physiological jaundice is unconjugated hyperbilirubinemia, and it does not extend beyond 14 days. So, presence of all these symptoms beyond 14 days is an indication that the child might have a surgical pathology, possibly a biliary atresia. And a classical features, of course, as I had mentioned earlier, is direct hyperbilirubinemia. Now, features of liver cell failure. As the disease progresses, like I said, it's a progressive cholangiopathy. The extrahepatic ducts are involved first, progresses to involve the intrahepatic ducts. So, as the intrahepatic ducts tend to get involved, liver cell failure sets in. Now, it is to be noted that liver cell failure is generally perinatal in its occurrence, irrespective of when this primary pathology occurs. For example, in a child with BASM, in which the pathology occurs the first trimester, cystic biliary atresia, in which the pathology occurs in the second trimester, as well as in the case of isolated biliary atresia, which can occur immediate postnatal period, liver cell failure progression remains more or less the same. You would normally expect in a child with an insult occurring in the first trimester to have a worse or earlier progression to liver cell failure, but it is not so. Now, fat-soluble vitamins. So, as the child progresses towards liver cell failure, the synthetic functions of the liver break down or they stop. So, once the synthetic functions get affected, you find the production of vitamin K gets affected, bile salts and bile pigments are affected, and when bile salts are affected, you find that fat-soluble vitamins like A, D, E do not tend to get absorbed. K is obviously not going to be synthesized by the liver because there is liver cell failure. So, these children tend to develop, have a higher chance of developing vitamin A deficiency, E deficiency, and D. The vitamin D levels are particularly low in these children. Vitamin K deficiency occurs because the synthetic function of the liver is affected, and these children progress towards portal hypertension and other features of liver ascites, portal hypertension, if not treated. In a child who's not been treated, the chance of survival is less than 10% at 3 years of age. Many of them don't make it past 2 years of age at all, if not intervened. Now, antenatal scans can detect biliary atresia, particularly the cystic variant. In fact, only the cystic variant of biliary atresia can be detected antenatally by around 20 weeks of gestation. In fact, at this time, at 20 weeks, it is most commonly thought to be a choledochal cyst. And the postnatal period, a postnatal ultrasound, is when we can come to a conclusion that it is not a choledochal cyst, possibly a cystic variant of biliary atresia. Now, diagnosis of biliary atresia. Like any other condition, diagnosis starts from the blood. So, LFT, a liver function test, can give us a clue regarding what type of jaundice the child is suffering from. So, generally these children have, as I mentioned earlier, conjugated hyperbilirubinemia, elevated liver enzymes in the form of elevated transaminases are noted. Alkaline phosphatase is obviously eliminated, but the most important enzyme which is elevated is the gamma glutamyl transferase. In fact, it is more than 100 international units per liter. It is very important because it is more or less specific in obstructive biliary pathologies, particularly in case of biliary atresias. We generally proceed with TORCH screening in children with biliary atresia to rule out the presence of associated viral infections. So, the TORCH infections that we look for are all the ones which had already been mentioned, and among them the most important is the cytomegalovirus screening. We also need to screen for the presence of other metabolic diseases, for example, like alpha-1 antitrypsin deficiency, etc. Now, this very important investigation, which is an AST to platelet ratio index, is said to be an extremely important investigation because it can help in prognostication and assessing the response to therapy. Now, it is a marker of impending liver failure. Now, a value which is low means that a child is not, a value which is low, okay, is more significant than an AST platelet ratio index which is high. So, because of its prognostic value, it is now being used regularly in the evaluation and follow-up of patients with biliary atresia. Now, ultrasound abdomen is one of the most important investigations in a diagnosis of biliary atresia. So, it has to be taken in a fasting state or a milk-free state, because providing milk or providing the child feeds will result in contraction of the gallbladder, and a normal gallbladder may not be visualized easily in an ultrasound. So, in biliary atresia, there are two important signs, namely the gallbladder ghost triad, which is basically a gallbladder size which is less than 19 millimeters or 1.9 centimeters, irregular contour of the gallbladder, absence of an echogenic mucosal lining. All these three components contribute to what is called as the gallbladder ghost triad. This is another classical feature of biliary atresia called the triangular cord sign. So, you can see here an echogenic area here, which is nothing but the fibrosed portal plate. So, a 4 millimeter, usually it will be around 4 millimeters in thickness. A 4 millimeter thickened, fibrosed, echogenic, possibly fibrosed portal plate noted on the anterior wall of the right portal branch of the portal vein, or the right portal vein, a right branch of the portal vein, is what is thought to be the triangular cord sign. I'll repeat it. It is nothing but a 4 millimeter thickening or echogenic thickening of the anterior wall of a right branch of the portal vein, which is the area where the portal plate is. So, it denotes a fibrosed portal plate. Again, this signifies the presence of a biliary atresia. Now, hepato-biliary scintigraphy. Now, hepato-biliary scintigraphy is again a useful adjunct in the diagnosis of biliary atresia. Now, it is commonly called HIDA, which is hydroxyimmunodiazolic acid. Now, It basically makes use of technetium-99M component, which is a metastable component, and to it is tagged this 99M radionucleotide has a molecule to which it is tagged, so that it can, as it is taken up by the liver and excreted into the biliary tree and subsequently into the bowel. So its entry into the bowel would signify that there is no obstruction to the biliary flow. Now, even though we say HIDA for every hepatobiliary scintigraphy, HIDA is not the only component which is used in hepatobiliary scintigraphy. We also have DISIDA, which is nothing but diisopropyl immunodiestic acid, which is more significant in the presence of severe jaundice or increased significant conjugated hyperbilirubinemia. It is more sensitive in such cases. Before proceeding with hepatobiliary scintigraphy in a child who is suspected to have biliary atresia, pre-treatment with phenobarbital has to be done at a dose of 5 mg per kilogram body weight per day. Always remember that delayed films are an essential component of hepatobiliary scintigraphy because the child could have underlying liver disease and uptake by the liver itself might be delayed. And we have to wait until 24 hours to say that there is no entry of the tracer into the bowel. This terminology, there is a terminology to denote this absence of entry of radionucleotide tracer in the bowel or into the duodenum. It is called absent intestinal activity. So, absent intestinal activity is a highlight, a hallmark feature of biliary atresia. It is basically absence or failure of the tracer component or this radionucleotide to enter into the duodenum. So, the radionucleotide doesn't enter into the duodenum, so it is not present within the duodenum, and this is termed as absent intestinal activity even at 24 hours. So, this is very important. To denote the entire sentence has to be said to denote the possibility of a biliary atresia. So, what are the fallacies associated with this? Now, if there is significant, as I said earlier, if there is significant liver cell failure, the liver itself may not take up the radionucleotide. So, if it doesn't take up the nucleotide, it obviously doesn't excrete. And you find that there are multiple other conditions wherein you may not be able to visualize the biliary tree. For example, you can have a plug or you can have bile duct paucity in which the liver might take it up, but it doesn't enter into the biliary tree at all. So, all these conditions wherein you may not be able to see the biliary tract and it may not denote the presence of a biliary atresia. So, hepatobiliary scintigraphy, while absence of intestinal activity in hepatobiliary scintigraphy is presence of intestinal activity in hepatobiliary scintigraphy more or less rules out biliary atresia. Absence of intestinal activity does not confirm the presence of biliary atresia. So, what can be done? So, this is an scintigraphy denoting uptake by the liver, but you find there is no entry into the duodenum, which means there is no intestinal activity, and even in 24 hours. Now, liver biopsy. Now, liver biopsy is said to be an investigation which gives the most accurate report as far as non-surgical tests are concerned. So, basically it is the most accurate non-surgical test. It can help us in differentiating between bile duct paucity syndromes like Alagille syndrome from biliary atresia based on the histological features which I already described about earlier. But one very common problem associated with liver biopsy is that it is very difficult to differentiate between parenteral nutrition associated cholestasis and biliary atresia. Of course, history will give us a clue, but then otherwise it is very difficult to differentiate between these two variants. Now, so the gold standard investigation to diagnose biliary atresia or to rule out biliary atresia either way is intraoperative cholangiogram. So, how is an intraoperative cholangiogram done? So, an intraoperative cholangiogram is an invasive procedure. So, the child under anesthesia has a subcostal incision is made. We enter into the peritoneal cavity, have a look at the gallbladder. If the gallbladder is distended, we put in a needle and aspirate. If we get golden yellow bile, it means that bile is entering into the biliary tree. In such cases, a purse string is taken on the fundus of the gallbladder and a 5 French feeding tube or a small Venflaw needle can be inserted into the gallbladder and a contrast medium can be injected. Now, this contrast medium that is injected is usually injected in the ratio of 1:1 dilution, or nowadays it is said that even undiluted contrast medium can be provided, which helps in better identification of the ductules. So once the contrast medium is instilled, we look for the entry of the contrast medium first into the duodenum. So you can see the contrast medium has been infiltrated, it comes into the cystic duct, a common bile duct is visualized, it enters into the duodenum, which means that the distal tract is patent. Sometimes you find that as we instill it, it enters simultaneously to the proximal tracts as well, delineating it clearly, in which case you rule out biliary atresia. Very commonly what happens is the dye enters only into the lower tract and does not enter into the upper tracts at all, in which case we might have to open the peritoneum over the common bile duct, apply a soft clamp over the common bile duct and reinstill contrast medium. So because there is an obstruction distally which has been induced by us, the dye tends to go proximally. So this will help us in delineating the proximal tracts very well. If we are able to delineate the common hepatic, the right and left hepatic, and to an extent the ductules, it rules out biliary atresia. So this picture rules out a biliary atresia, which is the reason why it is a gold standard investigation. One thing to be remembered while instilling contrast medium is that too much of force should never be used, because we don't want to delineate the entire intrahepatic anatomy need not be delineated, but the presence of the ductules or the good branching ductules need to be demonstrated. That's all. The only disadvantage is that it's an invasive process. So it is usually combined along with the definitive procedure. Now, before taking the child up for a definitive procedure or for a surgical intervention of any kind, these children have to be supplemented with vitamin K. So vitamin K supplementation is essential. Priming of the liver is also very important, because remember, these children are newborn or in early infancy. So the glycogen storage in the liver will be extremely less. These children are extremely prone to go in for hypoglycemic episodes. Hypoglycemia causes seizures, further worsens the general condition of the child. So priming the liver with 10% dextrose is an essential component in the preoperative care of a child with biliary atresia. Supplementing other fat-soluble vitamins also is an important component, basically ADE, along with vitamin K, which I have already mentioned earlier. Now, the surgical procedure of choice is a Kasai potoenterostomy with a Roux-en-Y jejunocejunectomy. Now, generally we combine an intraoperative cholangiogram along with a possible Kasai procedure. If you find that, like I had mentioned earlier, an intraoperative cholangiogram, you make an right subcostal incision is made, abdomen is entered, gallbladder is visualized, you put in a needle. If the gallbladder is atrophic on visualization, then we need not proceed with an intraoperative cholangiogram at all. You can proceed directly with a Kasai potoenterostomy. If the gallbladder is distended, we put in a needle and aspirate. If we get golden yellow bile, we proceed with intraoperative cholangiogram as described earlier. If we get mucoid material, or it's basically a mucocele, it again indicates that there is an obstruction and we need to proceed with a Kasai potoenterostomy in such cases. So Kasai potoenterostomy, the first step would involve mobilizing the liver. So mobilization of the liver has to be done by dividing the triangular and the coronary ligaments. The falciform ligament will already have been divided as we open the abdomen. So once the liver is divided, the liver is everted out for better visualization of the portal plate. One important point to be remembered while everting out the liver is that the infrahepatic IVC tends to kink. So the venous return might fall, and the anesthetist should be aware of this fact, and maintenance of cardiac output is an important problem to be taken care of here. So once the portal plate is visualized adequately, we are decided to proceed with the Kasai potoenterostomy. We mobilize the gallbladder, as we can see here, after taking a stay suture. So the gallbladder is slowly dissected off, or the atrophic gallbladder, whatever is present, is dissected off the gallbladder fossa. And as we come the cystic, as we call the cystic duct or the remnant of the cystic duct is again dissected. The cystic artery might be visualized. Now, identifying the cystic artery in this case is extremely important because it leads to the right branch of the hepatic artery. So, a cystic artery is a landmark which can give us an idea where the right hepatic artery is, so that it can be preserved adequately. A dissection is always done distally first, followed by proximally. Distally, we generally do not have any ascertainable biliary tract. Usually, it will be a biliary remnant, which is basically a skeleton of a biliary tract. And this biliary remnant is dissected distally to whatever level possible. Distal end is tied or transfixed, and this biliary remnant, subsequently dissection is continued proximally. After dividing the distal end, we proceed proximally. As we proceed proximally, you can see here, so this is the right branch of the hepatic artery, and you can see the cystic artery has been ligated here. So, this is the reason why it is very important. The hepatic artery can lie over the remnant of the common bile duct, or it can be on the side, or it can run behind as well. So, identifying the cystic artery and tracing it to the right hepatic artery is an important step. And as you can see here, you have the portal vein underneath. So, while dissecting the biliary remnant, we have to be very careful that we don't injure the portal vein. So, dissections continued proximally until the portal plate, as you can see here. So, once we reach the portal plate, dissection is continued posteriorly until you can see the caudate lobe of the liver. Then the dissection has to proceed laterally and medially. So, on the left side, dissection is carried on until you reach what is called as the recess of Rex. So, recess of Rex is basically where the umbilical vein joins the left branch of the portal vein. So, recess of Rex is an important landmark which denotes the end point of your dissection on the left side. And on the right side, dissection is continued until the right vascular pedicle is identified, and until the base of the gallbladder fossa is seen. So, you have to dissect hemicircumferentially around the right vascular pedicle until you reach the base of the gallbladder fossa from where you have taken the gallbladder out. So, that is the right extent. Basically, this is denoted by an area called Rubier fossa. So, these are the right and the left extent of dissection. Another important point is that sometimes while dissecting to the left, we might have to divide a small segment of hepatic parenchyma between the third and the fourth segments of the liver, which might have to be divided. The parenchyma might have to be divided to get access to the recess of Rex. So, once the dissection is complete, the next step is to excise the fibrosed portal plate. So, the fibrosed portal plate is this area here, and this excision of the fibrosed portal plate has to be done with the help of a knife or a blade or a scissors. Diathermy should never be used in the portal plate, because whatever minimal ducts which might be patent will get fibrosed by the heat generated by the diathermy, and cutting of the portal remnant, fibrosed remnant should be done only with the help of a scissors or a blade. So, once it is cut, we get a raw area like this with a lower margin along the portal vein. Now, while cutting, we might encounter small tributaries from the portal vein which might come into the line of our incision or the cutting, which have to be identified and ligated individually. Otherwise, we might encounter torrential bleeds. Even if minimal bleed occurs, we don't apply cautery or diathermy, apply compression using a gauze. We put the liver back inside. That itself will reduce the venous congestion and the bleeding might stop. Never make an incision over the parenchyma of the liver in cases in the hope of ensuring better anastomosis, because making an incision over the parenchyma rather than cutting the fibrous portal plate can initially give the appearance of a well formed anastomosis, but any scar or any cutting can result in fibrosis, which will subsequently ensure that the entire anastomosis becomes stenosed. So, to prevent that, we don't cut the portal plate, we only excise the fibrous portal plate We don't make any incision over it. We don't cut into the liver parenchyma basically. So once this dissection is done, we create a roux-en-y jejunojejunosmy. So you take a limb of jejunum about 10 centimeters from the DJ and it is transected. The distal end is closed and brought through the transverse mesocolon to the right of the middle colic artery. It is brought and placed in the subhepatic region. We take a length of bowel about 40 centimeters from the closed distal end, to which an end-to-side jejunojejunostomy is done. Now, the closed end which has been brought subhepatically, we make an incision on the side of it, anti-mesenteric aspect of it. And we proceed with an end-to-side anastomosis using either a 5-0 monofilament suture material, either in the form of a polydioxone, or we can make use of even polydioxone can be used of 5-0 Vicryl can also be made use of. Generally, because the anastomosis is in a precarious area which requires good visualization, parachuting sutures are always preferred, especially by closing the posterior layer. Anterior layer can be closed directly. The size of the anastomosis should at least be 2 centimeters because some degree of narrowing will occur in the postoperative period, and if the size is not at least 2 centimeters, we will end up with a stenosed anastomosis. And it should be some distance away from the end, from the closed end, at least 0.5 centimeters. Otherwise, we might again encounter the suture line if you close it too close to the suture to this end. If we link the anastomosis more distally, this will be a blind loop in which food materials or bile tends to get accumulated, resulting in stool formation and other complications. Once this anastomosis is done, we proceed with fixing the bowel to the transverse mesocolon. We have brought it through the transverse mesocolon. So if we don't anchor or make the bowel to the transverse mesocolon, there is a rent there through which it can herniate. And also the small bowel mesenteric rent at the site of the jejunal anastomosis also has to be closed. No surgery for biliary atresia is complete without taking a liver biopsy. A liver biopsy again gives us an idea regarding the histological feature, whether the classical histological features of biliary atresia are present or not. Moreover, whether there is associated cirrhosis. Like any other surgery, you can also have a laparoscopic approach to it. Generally, we make use of, you can see here, can have a 6-port technique can be made use of with an umbilical port. Now, this laparoscopic procedure, similar to how we can dissect using an hook diathermy. The gallbladder can be dissected. It can be dissected distally. The distal end can be cauterized and left because there is no discernible biliary tract there. Proximal dissection has to be carried out very carefully because the portal vein will be very closely adherent and needs to be separated the biliary remnant. Once you reach the portal plate, the entire portal plate has to be excised with scissors rather than diathermy, as we had mentioned earlier. Now, when we come to the roux-en-y anastomosis, generally what is done is that the measuring on the bowel loop is done laparoscopically. The bowel loop is delivered out through the umbilical port. We proceed with an end-to-side anastomosis and the closure of the distal stump. And then you push the bowel back into the peritoneal cavity and then proceed laparoscopically subsequently. So, we generally make a continuous anastomosis, end-to-side anastomosis between the portal plate and the jejunum. So, anastomosis is continuous, so that because this is easier done laparoscopically. Now, are there any advantages of doing a laparoscopic Kasai when compared to an open Kasai procedure? Other than the scar and the relatively less inflammation, if the child needs a transplantation at a later date, the outcome does not seem to vary based on whether it is done laparoscopically or in an open technique. Now, role of steroids. Now, steroids are said to play an important role in the management of children with biliary atresia, especially in the post-operative period. Now, generally low dose prednisolone 2 mg per kilogram per body weight per day is said to have a cholinergic effect, anti-inflammatory effect, reduces the progression of the disease, and hence clearance of jaundice because it's a cholinergic agent. You have an earlier clearance of jaundice. But does it ensure that the child does not require a transplantation at a later date? No, because the chances that a child can require a transplantation is the same irrespective whether you put the child on steroids or you don't do it. Steroids can help us in the earlier clearance of jaundice, but long-term progression to transplantation is not altered by the administration of steroids. So subsequently, since low-dose steroids did not seem to have an effect on the overall incidence of requirement of transplantation, its dose was subsequently increased to 5 mg per kilogram body weight, which again did not significantly impact progression towards a requirement of a liver transplant. This trial, called a START trial, was done in the United States, wherein they couldn't demonstrate any significant beneficial effect of steroid in the post-operative management of children with biliary atresia. But UK trials, there are many UK trials which have demonstrated at least some response to steroids with a 15% response, and hence routinely, especially in United Kingdom, administration of steroids, particularly prednisolone, is recommended. Now, so why would you want to go through the ordeal of performing a Kasai portoenterostomy when many of these children will require a liver transplantation at a later age? Now, it is to be remembered that Kasai procedure, the response to Kasai portoenterostomy can be divided into three. One third of, if you have 100 patients, 33% of them, that's 1/3 they respond extremely well to Kasai portoenterostomy and do not require any surgical procedures later on. These are called responders. There are next 1/3 are partial responders. That is, they respond initially with clearance of jaundice and passage of green stools. Then over a period of time, they tend to progress towards liver cell failure. The third category are non-responders, which is the third 1/3, the other 1/3 are non-responders, and these non-responders will end up with a liver transplantation. So basically, around 66 to 67% of children tend to end up with liver transplantation, which begs the question, why don't we go ahead with a primary liver transplantation in these children? Now, it is to be noted that liver transplantation in a child is no mean feat, because one, it's a significantly morbid procedure. The availability of donor liver is extremely important, whether it's available or not. The surgical technique involved is very meticulous, has to be very meticulous, and with microvascular suturing will be required. And also, these children are going to be put on immunosuppressants, making them extremely susceptible to vaccine preventable diseases, because these children, because of immunosuppression, may not be given live attenuated vaccines. So they are extremely susceptible to vaccine preventable diseases particularly. And moreover, by doing a primary liver transplant, we are denying those children who are likely to benefit from a Kasai portoenterostomy, in whom possibly a Kasai portoenterostomy itself might be sufficient. You are unnecessarily exposing them to an even more morbid procedure in the form of a liver transplant. So generally, primary liver transplantation is recommended only for those children who present beyond 100 days, that is basically a delayed diagnosis and presentation, and who come with severe liver cell failure. So outcomes of biliary atresia, surgery for biliary atresia. Now, it depends to a large extent on the age at which the surgical intervention has been done. So generally less than 100 days is what is thought about. In isolated biliary atresia, progression is not very severe not very rapid as long as the child is less than 100 days. Beyond 100 days, the progression seems to be more rapid, and these children tend to develop liver cell failure at a rapid rate. Another important feature which determines the outcome of a surgical intervention is a microscopic examination of the portal plate. So a ductule size of more than 150 microns would indicate a good prognostic factor, indicating adequate caliber of the ductules, facilitating bile flow. And of course, I had mentioned earlier, the response to surgery also provides an idea regarding how this child is going to progress later on. Biliary atresia, surgery for biliary atresia is also associated with its own complications, cholangitis most commonly. So, cholangitis is very common in biliary atresia when compared to another surgery involving the biliary tree in children called choledochosis surgery. Possibly because in biliary atresia, the flow of bile is very less. So, hence you find that the chances of cholangitis or the chances that the anastomosis can become stenosed, narrowed, etc. is very high, resulting in cholangitis. And these children with cholangitis are usually gram-negative organism induced and need high-end antibiotics to tide over the crisis. Portal hypertension. So, portal hypertension, those children who undergo Kasai portal enterostomy, progression based on the time period involved, especially those delayed cases, they might progress towards portal hypertension as the natural cause of liver cell failure. Most commonly, as you would expect in adults, we have varices occurring, variceal bleeds occurring, and full-blown hepatic liver cell failure in the form of ascites can occur. Now, the earliest appearance of varices is generally around 9 months after the surgery is being done, and full-blown liver cell failure to occur in non-responders, it takes around 2 to 3 years. So, with this, we come to the end of a very important topic, which is biliary atresia. I hope I have made myself clear regarding the various concepts in biliary atresia. So, thank you one and all for tuning in and listening to this lecture on biliary atresia. Thank you.